For our next case discussion, we'll have some repeats up here. As you know, Dr. Feuer and Dr. Watkins will be joined by Dr. Alpesh Patel from Northwestern and Dr. Victor Chang from Henry Ford. And so the case we're going to be talking about today is cervical pseudoarthrosis in an athlete. And it's not so much of a debate rather than a discussion of how to best sort of treat these athletes, where there's not a lot of literature out there to guide how we're working with them. So this is a 31-year-old lacrosse player. Neck and bilateral arm pain with some numbness and tingling down the right arm to the thumb and index finger. And that's what the lateral cervical x-ray in a neutral position had showed us at that time. And this is the surgery that he underwent. So you see it's a C5-6 anterior cervical discectomy fusion with a P cage. And so some starter questions for this group. When would you allow them to return to cardio activities? When can they return to practice? And eventually, sort of a full return to sport? So Dr. Patel, we'll start with you.
Great, really important questions. And I think this is what our patients will oftentimes ask us, even before we do the operation, right? They want a game plan for what life looks like after their surgery. And so hopefully you have these discussions on the front end, not on the back end. I think the answer obviously is it depends on the individual, what their level of sport is. Lacrosse is a collision sport. And he's a professional lacrosse player, if I saw that correctly. So again, the goals and expectations are different. Cardio for these individuals, one of the speakers earlier talked about not letting these people lose their fitness. And I think that's unbelievably important, right? That their general overall fitness, independent of their spine, is their differentiator in their athletic talent. And so that we start actually very quickly. I would say within a 2-week window, they're back to doing cardiovascular work. Low impact, and again, with a progression over the course of the next few months. Contact practice, practice, non-contact, then contact, and then full sports comes later. With most ACDFs, I'm laying out a plan typically for about 6 months for collision sports to get them back. But that's sort of what the conversation would be. And again, I would encourage anyone taking care of athletes to have that conversation on the front end.
Yeah, I mean, I think especially with a contact athlete and a fusion operation, I know the classic teaching is to look for evidence of some bony bridging, some arthrodesis before you allow them to return to full activities. And so, with that, some of that kind of plays into what your your interbody device choice of material might be as well. And so, that's an important consideration as well.
Yeah, and we remember these athletes are still healing from the surgery itself, and even though it's light cardio activity, they may still be experiencing some neck pain as they're recovering. And how do you counsel them in terms of returning to those light sort of cardiovascular activities and the lingering neck pain that they have just from the surgery itself?
Having a program outlined, what I've gone towards is, one, we have an app that has 5 levels of spine stabilization. So when people say, when can I do a certain activity, you got to get to level 2 before you can do low impact cardio. And athletes are straightforward. Just tell them what to do. And if it's too complicated, they're not going to listen. It's got to be get to this level, then you can do this. And having that written out with time points, and being held to a time point's difficult, because if they don't make the time point, everybody wants to know, well, who failed? Why didn't they make it? Or did they go back too soon? But you put a range on the time. But I've got an email that has, when you get to level 2, you can do low impact cardio, and that's usually 4 to 6 weeks with a time frame in there. And if you can put that ahead of time, like you said, give that to them ahead of time, give that to the agent and the trainer ahead of time, everybody can relax. Because otherwise the tension, they're getting asked every day, when can they go back, when can they do this? If there's some schedule and time frame on there that's structured and has the rehab in it, with levels in it, it takes a lot of those questions and the stress away, where everybody knows it. And so, but the pain afterwards is a tough one. If you're having some discomfort, ultimately if it's a fusion, I let people go back pretty quickly because it's stable. It's just no head contact until 3 months. And at 3 months, I'd get a CT scan and flexion extension x-rays. So I wouldn't do any head contact before 3 months. They could do just about everything before that point.
Yeah, and that's sort of the timeline that we gave him as well. So, here were x-rays at 6 weeks and x-rays at 3 months after surgery. The radicular symptoms had resolved. soon after the surgery was performed. The neck pain, gradually improved over the next 2, 3, 4 weeks with some shoulder soreness, but that also improved. And so relatively asymptomatic at the 3-month time period. So he returned to training and practice at around 3 months. At that point, it actually felt pretty good. Returned to game action at around 5.5 months and reported after the first couple games that, he felt pretty normal, in fact, and did not feel even the mental hesitancy in returning to play. Sometime around 11 months, his neck started to become more sore. I guess that was around 9 to 10 months. And at this point, this is what the x-ray looks like. And I just posed this question, but we can answer on the next slide. What do you tell this athlete with playoffs approaching and this being his livelihood? And then 4 weeks later, now about a year post-op, the neck pain is worsening, some right arm pain. He underwent an epidural steroid injection, which actually resolved his radicular pain for a week, but it quickly returned to his pre-injection levels of pain. And so now what, right? He's still playing. He's trying to fight through the soreness that he's experiencing. The playoffs start next week. He tells you he feels as though he can play because the pain is just annoying. And so you'll see some of the questions there, right? Can he finish playing this season? Does not want another surgery and thinks that he can even play through this into next season. He wants to play internationally during the off season, just to stay active and then keep his skills up. And then, after that, are we looking at another surgery down the line here for this patient? Dr. Feuer, would love your thoughts on this.
I think I would have done what you did. You let him keep playing. I don't know how much neck turning they really did. They deal with quite a bit of that lacrosse, but let him keep going. You let him. Yeah, you did leave. You did let him play. When they start getting more symptoms in the arms, I think then you have to go over the CT scan again. Repeat that. What you did, see if you have any stalagmites and stalactites coming together somewhere that that may really make it relatively safe. Remember, looking at the X-rays, that plate hadn't budged. There's no screw back out. It's got a nice lordosis right at that level from what you've done. So it's a matter of what he can get away with and how does this affect his play. Is he great between games? Does it just bother him a little bit during the games? That's how I start. That's how I make my final decision as to whether more surgery is needed or whether he just has to take some time off. Whether that's going to make any difference, probably not going to make any difference at that point in time because it's recurred. It keeps recurring.
And Dr. Yoon, this guy's begging to keep playing.
Yeah, I mean, I think this is kind of like a stable pseudo. So the inner body has infused, but the screws and the plate is intact. I mean, it's 11 months out, so there's still a pretty big gap there between the graft, the inner body. So I don't think this will fuse by itself. But this is at this point, it's more of a quality of life, and he's sort of if he can fight through that pain and just treat it, then I'm okay waiting. And obviously, if it becomes unstable pseudo, then I think that'll force your hand to go back and revise this. But I think off season, I think it would be reasonable to consider revision. And this for that reason, I kind of stay away from using a peak in an ACDF. I favor allograft or even a titanium cage over peak for this reason.
Yeah, I'd say that it fits a lot of conversation we have with athletes and is what is the risk? What's the risk of a catastrophic injury? Because that's really the reason why we'd say, no, you can't play. And so in this case, the risk of a catastrophic injury and spinal cord injury is so low that he can play with this. And it's similar to a lot of the cervical stenosis cases we have where maybe they have stenosis, the space available for the cord is only 7 millimeters. It's not ideal to play, but what's the chance they're going to be paralyzed and have a catastrophic injury? If it's extremely low, well, then we may still clear them to play. So it kind of comes down to that catastrophic injury. And if it's pretty low, you typically would let them play. As far as the implants being put in, we typically use a PEEK spacer, titanium-coated PEEK with iliac crest autograft in the middle. And we harvest the autograft with a cylindrical drill. It takes 5 minutes, just a core plug of their bone, because we found pretty good success with that. And even put some of the autograft in the front of the cage and then the plate on top has been a pretty good combo of not taking a full tricortical iliac crest, which can be unpredictable as to the shape and the stability. And so we've kind of gone to a hybrid of both and pretty good success.
Rob, you're doing it in the professional athletes.
That's correct. I take iliac crest autographed in every professional athlete and maybe a 3-level ACDF. Most of my normal patients with 1 or 2 level ACDFs, I do not take iliac crest.
Yeah. Interested. Just to keep things moving here, he did finish the season. He eventually underwent posterior stabilization as well and did very well from this and has been asymptomatic since. So it leads us to these questions I want to close with and really ask Dr. Patel first to sort of lead us off with this in terms of, what sort of evidence do we have at this point to support the decisions in a pseudoarthrosis athlete? Because I know it is one that is not all that commonly written about nor studied. And then obviously with the team and the agents and the legal issues that all arise in the professional forum.
Yeah. I can answer that. The short answer is not much at all, right? It's a lot of anecdotal evidence. But I think when you're talking about the care of high-level professional athletes, for example, right? You're never going to have the level of evidence that we have for the general population. So we have to accept the notion that you're not going to have perfect or complete evidence. And that we do make a lot of decisions based on experience. We make a lot of decisions based on, unfortunately, sometimes what worked most recently, right? That tends to drive some of our decision-making as well. So we don't have a lot of evidence. We do need to, and yet at the same point when we're having these conversations, inside this room, we can talk about the uncertainty and the variables in play. But when we're having this discussion with the athlete, the manager, the agent, the family, whoever it is you're having a conversation with, you need to come across as being very, very definitive, right? And so that's the challenge I face oftentimes in having conversations with the professional athletes is getting across the notion that, we're doing what we think is best, we're doing what we know from experience, and yet we don't have strong evidence to support one treatment from another, one graft from another. That's a discussion you have to figure out if you want to have that or not with the athlete. I think the one thing here that we skipped over the first line, which is symptoms, right? I think that is unbelievably important in the evaluation of a pseudoarthrosis. That's true for our patients who aren't athletes, especially true for the athletes that if they're having completely asymptomatic pseudoarthrosis, I think you watch them and you can go along with continued observation, let them play, let them compete. For me, at least, once it pivots away from asymptomatic and maybe even just minor axial symptoms, it sounds like that's what this guy had, and it gets into more radicular symptoms, or certainly as soon as you cross into a level of neurological involvement, either with sensory deficits or obviously motor deficits, then there's hard stops you come across, right, on letting them continue to play.
So with the radicular pain, would that prompt a change in the sort of the current schedule of following that patient?
Yeah, well, I think, when, you go back to your first principle. So as neurosurgeons, spine surgeons, we're here to preserve neurological function and protect neurological function. So when someone starts to develop radicular type symptoms, then especially at a level that you already operated on, you start worrying about whether or not within the physiologic load, whether the spine can take that. And then when you talk to your sports colleagues, I know the orthopedic surgeons, they have this part of their training. So for neurosurgeons, it's relatively, maybe less treaded ground. But when you talk to what are the goals, you basically want to be able to return the athlete to activity and protect them from re-injury. And so once you've, crossed that threshold, at least in your opinion, and there's not great evidence to support it, it's just, what you believe is best to preserve those principles.
I think we didn't touch on this, but C4-5 level always makes me really nervous because the C5 nerve. So if the athlete shows up with the C5 symptoms and they have a little bit of deltoid weakness, I think that always makes me nervous that, no matter how you do, you can get C5 palsy. I think average Americans, if they have a little bit of C5 palsy, it's not a big issue, but for these athletes, that could be a career ender.
And that's the important point. And we'll just sort of wrap up the session with, in these last couple of cases, these are very common situations and pathologies that we see in our everyday patients. But when you add the sort of change in who the patient is and in a professional athlete, all of a sudden these decisions become much more difficult and there seems to be more on the line. But just want to thank the panelists for joining us and thank you all. And we'll move on to the next portion of this session.